بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. Welcome everybody to our critical care online course. Today is the fourth day. I am Dr. Qandil. I am the course facilitator. In critical care medicine, being up to speed is not a choice now. It's necessary. For this reason, this course was started on Sunday and continuing till tomorrow in cooperation between Qatar Society of Critical Care and IUG Medical College in Palestine. In addition to welcoming you to the course, I would like to welcome our lecturer for today, who spare their own time to make this course real and to help this educational course to progress more. So it's my big honor to introduce Dr. Saibu George. He's an ICU consultant and hemodynamic lead in critical care. And also I would like to introduce Dr. Ahmed Abdessalam. He's a senior consultant in neurocritical care medicine. He's the program director for the medical ICU fellowship. He's an expert in his field. Today we are going to do two lectures. The first lecture will be with Dr. Saibu about hemodynamic monitoring in shock. The second lecture will be about sedation and agitation management in ICU patients. We are here for you, and these two lectures will help your progress in the critical care medicine and your actual clinical experience. So at any time, if you have any query or question, you can send a message, or if we mention that you can unmute yourself and participate with your voice, you can do this. Thank you very much for everyone. Dr. Saibu, you can start.
Good evening, everybody. Especially a warm good evening to all our friends in Gaza and all our colleagues here in Hamad General Hospital in Doha, Qatar. I have almost 63 slides, so I was hoping to start at 6 p.m. exactly. So I might have to rush through a few slides, but I think so. I have 50 minutes left so that we can go in a smooth way in this talk. So my talk is about hemodynamic. Is it clear for everybody?
Yes, the voice is clear.
Okay, so my talk is about hemodynamic monitoring in. How do you change slides?
Just usual, either the arrows or on the keyboard. Yes.
Okay. Okay. So I don't have any conflict of interest. Learning objectives for this topic would be, we'll talk about preload assessment and fluid responsiveness. We'll talk about the various invasive hemodynamic monitoring that we routinely use in our ICU settings. And I think it's very important that we touch base about pulse control, cardiac output monitoring, otherwise commonly known as PICO, which is commonly used in most of the ICUs, critical care units. So before that, I would like to rejuvenate your cerebrum. So let's ask a few questions, and then inshallah, once we have time, we'll come back to these questions. So the first question to the audience, if it's not mandatory that you need to answer now, it's just pick the wrong answer among this. For example, factors that directly affect hemodynamic monitoring are A, vascular tone, B, cardiac contractility, C, venous return, and D, cerebral perfusion pressure. Definitely we'll come back to these questions. The next question, arterial pressure monitoring. So which among this is true and which among this is false? The ulnar artery is the dominant blood supply to the hand. Allen's test should never be performed before doing an arterial line insertion. This systolic blood pressure measurement in the dorsalis pedis artery will be 10 to 20 millimeter mercury lower than in the central circulation. During spontaneous breathing of a normovolemic patient, intrathoracic pressure and lung volumes produce cyclical variations in the blood pressure. The mean arterial blood pressure is a product of your systolic blood pressure minus diastolic blood pressure plus 1/3 of your diastolic pressure. Regarding passive leg raising test, we start with PLR from recombinant position to semi-recombinant position. A stroke volume variation more than 12% is consistent with fluid responsiveness. Passive leg raising test with pulse pressure variation has more sensitivity then pulsatile grazing test with PICO monitoring. PLR is contraindicated in patients with cardiac failure. In relation to PICO, central line is only needed. So if you want to put a PICO monitor, do you need only the central line? The thermodilation is needed to calibrate the pulse pressure algorithm. Mean transit time represents the time taken for all thermal tracer to pass through the venous circulation, heart, lungs to the arterial circulation. And pulmonary thermal volume can be calculated from the downslope of the mechanism in which you get the readings. And the extravascular lung water index is a poor marker for mortality in ARDS. The last question, just before we go to the topic, is electrical bioimpedance cardiac output monitoring. It performs well in critically ill patients. It's invasive. It measures variations in electrical impedance caused by vascular blood flow. You can estimate changes in cardiac output with electrodes placed on thorax, and it may be conducted with electrodes placed on limbs. As I promised, we'll come back to these questions because most of the answers of these questions lies on the topic that we are going to discuss today. So what is shock? Basically, whenever we talk about hemodynamic monitoring, it's very imperative that we should know what is shock. There is a different definition of shock. In simple words, shock is an acute circulatory failure state, or it is just a state where you're deprived of oxygen utilization, where the cells are deprived of oxygen utilization. Now, it's very important to know the train of shock. We all know that there are 4 different kinds of shock that we always deal with in our daily life. That's a septic shock that comes in the group of distributive shock. There is the obstructive shock, cardiogenic shock, and hypovolemic shock. Remember, any shock starts from a hemodynamic instability with low blood pressure, tachycardia, all those things. And then it goes to reduced organ perfusion, which in turn leads to altered tissue microcirculation, tissue hypoxia, and of course, at last, if not treated on time, it leads to onset and maintenance of multi-organ dysfunction. So basically, our aim when we deal with shock is to prevent this. We need this train not to reach from A to B. We need to catch the patient earlier. Whenever we find that there is a hemodynamic instability, we need to catch the patient early in shock to treat him. Because the more we delay in recognizing and in treating shock, unfortunately, we reach to the end of the tunnel. That's the onset of multi-organ dysfunction, where the mortality actually doubles. So what is hemodynamic monitoring? So hemodynamic monitoring is basically, it's either an intermittent or a continuous observation of physiological parameters pertaining to the circulatory system. And it is in a view for early detection of therapeutic intervention. So remember one thing, if you do hemodynamic monitoring for a patient, and if you don't intervene, then that's not hemodynamic monitoring. So hemodynamic monitoring is not only to look at the parameters, it's also to intervene. Just a snapshot of your circulatory system, your pulmonary circulatory system, and your systemic circulatory system. So basically, this is the answer of the first question that we discussed about the hemodynamic things. So it's very important that we need to know about the venous return, the intravascular volume. The venous return is basically your SVC and your IVC draining to your right atrium. So that's very important that we should know about the venous return, because if you have a low venous return, you know what kind of shock you're dealing with. At the same time, heart rate and contractility is very important to maintain the pump function of the cardiac. And of course, the vascular tone. This is very important. So now once we discuss about these 3 things, that the venous return, heart rate and contractility, and then vascular tone, then invariably, you know that what kind of shock you're dealing with. So can somebody among the audience, just to be, as I want this to be interactive, can tell me one shock, and from this picture, tell me that shock is related to which part of the system? Tell me about one shock that you always follow up, and then tell me in which part of the system it correlates.
Vascular tone.
Vascular tone. So what vascular tone? So if you have an impaired vascular tone, what kind of shock are you dealing with?
Distributive shock.
Excellent. So if you have a pump failure, what kind of shock are we dealing with?
Cardiovascular.
Cardiogenic shock.
Cardiogenic shock, yeah.
If you have a volume loss,
Hypovolemic shock.
Hypovolemic.
Excellent. So you have decreased venous return. You have a patient with acute GL bleeding. He has exsanguinous bleeding, and then he has volume loss. You're dealing with hypovolemic shock. Then you have something called the vasodilatory shock, as you mentioned. Our colleague mentioned this before. Vasodilatory shock. You have reduced vascular tone or increased, reduced systemic vascular resistance, actually, in distributive shock. And of course, the fourth shock, which is less common among these shocks, is the obstructive shock, where the most common entities that come in obstructive shock is pulmonary embolism. So the initial and very crucial steps when it comes to treatment of shock is clinical assessment. My dear colleagues, no matter what equipments that you have in your daily practice, in your critical care, remember, bedside examination of the patient is crucial. And even if you have the latest artificial intelligence hemodynamic monitoring with you, this clinical examination or the clinical assessment of the bedside examination will never be replaced. So clinical assessment of the patient in hemodynamic monitoring is very important. So let me just give you a small example. If you are going to see a patient and who's deemed a shock, and when you examine him, his skin is cold and calming, and his blood pressure is narrow, what kind of shock are you dealing with, roughly?
Hypovolemic. Hypovolemic.
Or it can be
Cardiogenic. Cardiogenic.
Cardiogenic.
Excellent. So that's clinical assessment. So that's bedside examination of your patient, looking at the blood pressure, whether the blood pressure is narrow, whether the blood pressure is wide, whether the patient has a reduced capillary refill or increased capillary refill, examination of the skin, seeing microthrombitis or anything, petechias, anything. So these are all clinical assessment of hemodynamic monitoring. And then comes the basic monitoring and assessment of global perfusion. Of course, in basic monitoring, you have the SpO2, you have the blood pressure, you have the heart rate, you have ECG and all those things. Then when you want to be more conclusive, then you go to the preload monitoring and fluid responsiveness. Of course, in my next slide, I will talk to you about preload monitoring and fluid responsiveness. The advanced hemodynamic monitoring comes where you are going for direct cardiac output monitoring. You assess for cardiac contractility, and you're looking for assessment of tissue perfusion. That's when I talk about assessment tissue perfusion, you're looking for either global tissue perfusion, that's either you look for something called lactate, or you can look for regional tissue perfusion with new machines called spectroscopy and all those things. So let's talk about preload. If I ask a layman, what is preload? What should I answer to you? What is preload?
It is the amount of blood that retained through the vena cava to the heart. Is it?
Basically, so that means basically to be more more physiological, preload is a degree of cardiac muscle tension at the initiation of contraction. So that's your preload. In a layman term, you can say it is just your degree of venous return. Because preload, when you say preload, what parameter do you look for preload in your ICU? A simple thing. If you have a central line, what do you tell the nurse to connect to it?
Central venous pressure.
Excellent. You look at the CVP. CVP is a static parameter of your preload. Then right now we are in this era of looking for dynamic parameters of preload. So we'll come into the next slides. What are the dynamic parameters of preload? So when we talk about preload, we need to know the definition of fluid responsiveness. So what is fluid responsiveness?
Sorry?
What is fluid responsiveness? Fluid responsive. That means if I give fluid to this patient, the patient's dash should improve. What should improve?
Urine output, heart blood pressure, and I think it's,
okay, so basically, if your urine output is improving, means your cardiac output has improved. So basically, the definition of fluid responsiveness is the response to fluid challenge with an increase in cardiac output or stroke volume more than 12% or between 10 to 15% is defined as fluid responsiveness. Now, this is a very important thing that we should all understand, the Frank-Starling curve, my dear friends. So you have the stroke volume on the x-axis and the ventricular period on the y-axis. You should understand one thing. In this diagram, you know that whenever you increase the preload, that means whenever you give fluid to the patient's stroke volume increases. If the patient's stroke volume increases, the patient's cardiac output increases. But my dear friends, there is a limit. There is a plateau phase where in spite of ventricular preload, in spite of giving fluid, the patient's cardiac output doesn't increase. If you have reached that limit, and if you're still giving fluids, what will happen?
Pulmonary edema.
What all? Anything. Pulmonary edema, gut edema, cerebral edema.
Yeah.
I mean, you have anasarca, you have fluids stuck.
Yeah.
Excellent. So why am I showing you this very important diagram to you? Because my dear friends, when we talk about hemodynamic monitoring, we are trying to de-escalate our fluids. Because yes. So I'm trying to tell you that, see, patient X doesn't need fluid anymore. Why? Yes, because I have done something called, I have done an echo on him. I have looked at his IVC, or I have done a pulse pressure variability on him. And it shows me that the patient doesn't need any more fluids. So that's where we need to check. So this is what the reason. The only reason to fluid challenge is to increase stroke volume. If there is no increase in stroke volume, volume loading is of no benefit and can be harmful. Heart-lung interaction is a big subject, and I'm telling you, it's one of the most important subjects when it comes to critical care. And I'm trying to teach you heart-lung interaction in just one diagram, which is very difficult. But because of constraints of time, it's just a heart-lung interaction in a nutshell. So what happens when you are breathing right now spontaneously? When you're taking a deep breath, you have a negative pleural pressure. Okay? But the moment you put somebody on a ventilator and gives him PEEP, that's positive end expiratory pressure or positive pressure, his pleural pressure changes. So you have an increase in pleural pressure. And remember, Dr. Taslim said yesterday, transpulmonary pressure, which is the difference between your intrapleural pressure and your alveolar pressure. The transpulmonary pressure increases and your RV preload decreases, your RV afterload increases, and your LV preload increases. This is during the inspiratory phase. But at the maximum end inspiratory phase, what you will see a decrease in RV stroke volume and increase in LV stroke volume. That's during the end inspiratory phase. Whereas in the expiratory phase of your ventilation, you will have reduce in preload and reduce in RV stroke volume. By showing you this figure, can you answer to my question? Which part of the heart likes PEEP? The RV or the LV?
The RV, yeah. Right ventricle.
Likes the PEEP. Which part of the heart likes PEEP? Give me more PEEP. Give me 8 of PEEP. Give me 10 of PEEP. Look at the picture and do you want to change your answer?
Left.
Yes. So that's why, my dear friends, remember the biggest trials giving CPAP on people with pulmonary edema. So what happens is that when you give positive pressure to people with pulmonary edema, the positive pressure reduces the preload and reduces the stress forces to the heart. Where unfortunately, the right heart doesn't like PEEP too much. So if you have a patient with interstitial lung disease who has right heart failure, or somebody else with COPD with severe right heart failure, or any kind of chronic lung disease with right heart failure, and when you give them PEEP, the right heart fails. If the right heart fails, consequently, the left heart also fails. So basically, the left heart likes positive pressure. The RV usually doesn't like too much of positive pressure. So, as I mentioned before, there are two ways of looking for preload. One is the static parameter. That's an old technique where you look at the CVP or put a pulmonary Swan-Ganz catheter and look at the pulmonary artery occlusion pressure. Whereas the best way currently, and most of the studies are proving, is to look at preload by dynamic measurement. So what are the dynamic measurement of looking for preload? Pulse pressure variability, stroke pressure variability, systolic pressure variability, stroke volume variability, inferior vena cava variability, distensibility, or SVC distensibility. Because of constraint of time, we will only discuss about pulse pressure variability and IVC variability. So let's talk about pulse pressure variability. Before talking about pulse pressure variability, you need to have an arterial line. So how do you put an arterial line? Of course, you usually choose your radial arterial line. You have to do the Allen's test, look at which is the most predominant artery, and look at any change in color once you do the Allen's test. And once you insert the arterial line, we connect the arterial line to a transducer. Transducer is a machine which changes mechanical energy to electrical energy. So this is a system where the arterial line, once you get the arterial line waveform, we look at something called pulse pressure variability. So how do you look at pulse pressure variability? In wherever you are working in all over the world, you might have the Philips monitor with you, or a Nikon Cordon, or any other kind of monitor with you. You take a rhythm strip of that monitor where you have 30 boxes and look at the pulse pressure variability. So when you mean pulse pressure variability is the difference between the pulse pressure. For example, if the systolic pressure is 100 and the diastolic 60, what's the pulse pressure?
40.
40, excellent, excellent, 40. So the difference between systolic and the diastolic is the pulse pressure. So pulse pressure variability, as I shown you in the formula, this is the formula to get the pulse pressure variability. But there is a good news for all you people. The new Nikon Cordon and the new Philips monitor are already have a module in which you just have to connect and check the pulse pressure variability. The machine itself will give you pulse pressure variability rather than you taking a rhythm strip and doing the measurement. So this is how you do a pulse pressure variability. But in order to check for pulse pressure variability, there are a few prerequisites. Okay, you have a sensitivity of 94% and specificity of 96%. So if you have a pulse pressure variability of more than 13%, this means the patient is a fluid responder. Now, what are the prerequisites for checking for pulse pressure variability? Number one, the patient should have sinus rhythm. If the patient has atrial fibrillation or SVT, unfortunately, you cannot rely on the pulse pressure variability. Number two, there should be absence of spontaneously ventilator effort, or means the patient should be sedated. The patient should be passively breathing, not actively breathing. What happens when he's actively breathing? There is a difference in the cyclical variations of the pulse pressure, so that will give you a wrong this. And of course, you should have absence of right heart failure. So these are the prerequisites for checking for pulse pressure variability. Giving these prerequisites, according to Dr. Taslim's lecture yesterday, would you check pulse pressure variability in patients with ARDS? Because I did not mention this in the prerequisite. This is the one I wanted to mention. Remember, one of the other prerequisites is that the patient should get a tidal volume of more than 8 ml per kg. So people with ARDS usually get lower volumes, like 4 to 6 ml per kg. So unfortunately for those patients, pulse pressure variability would not be a good variable to look for hemodynamic response monitoring. So the next thing is about passive leg raising test. This is a test, my dear friends, I want you guys to practice day by day, because it's a very cheap test and you don't need anything extra to it because you do it by yourself. So what are the steps to do passive leg raising test? Number one, make sure the patient is at 45 degrees before you do any manipulations. And of course, the patient is connected to a real-time cardiac output monitoring machine, either a PICO, or you can use an ECMO, or you can use a pulse pressure, or you can even use a simple heart rate to see the response in the change in the heart rate. And then you adjust the bed. Do not touch the patient, because if you touch the patient, there is increased sympathetic activity. So try to avoid touching the patient. Most of the new beds available in ICUs they are manipulative, and you can change the position beds by using the knobs. You assess the PLR with the cardiac output and use real-time cardiac output monitoring. And the most common real-time cardiac output monitoring that we use in our ICUs are the Vigilo or the PICO or ECHO. And you reassess the cardiac output after you keep the patient back to the same old position. So this is how you do passive leg raising test. If you do this test, and if you see by ECHO or by PICO or by Vigilo, whatever machines that you have, that the cardiac output has increased more than 12%, that means the patient needs fluids. There are lots of studies claiming that passive leg raising test is one of the best indicators for fluid response in septic shock. This is by Zhu Zhongdong. It's a Chinese article and his colleagues. And another by Cavallaro and colleagues, which also confirm the diagnostic accuracy of fluid passive racing test. And also this is a systematic review, actually a meta-analysis showing how good the sensitivity is when you do a passive racing test for predicting fluid responsiveness. Remember one thing, the best way to do PLR is when you have a real-time cardiac output monitoring. So for example, if you have a PICO with PLR, which is more sensitive than PICO with pulse pressure variability. Oh, sorry, with PLR with pulse pressure variability. A very important tool that, my dear colleagues, that you should have in your ICU, that's your ultrasound. You cannot master echocardiography, but you can learn, you can try to learn. Remember, echo helps you in a lot of things. Echo helps you in diagnosis and also actually in diagnosing the shock and also in hemodynamic monitoring, also looking for fluid responsiveness. So as a diagnostics tool, you can use it for pericardial effusion, severe LV dysfunction. As a monitoring tool, you can use it for looking for preload assessment and fluid responsiveness. Now, can somebody look at this image and tell me what's happening? What do you want to do with this patient? Just closely look at the LV, the RV, left atrium, right atrium. What do you see in the LV? So the LV is in your, if you're looking at the image, it's in your right hand side. Anybody would like to discuss about this? What do you see? The LV wall is kissing each other. Am I right? So if you see this, what would you like to give the patient?
Fluid.
Thank you so much, because this shows that the LV walls are kissing each other. This shows that the patient can be. Remember, one window, whenever you do an echo, one window is enough to look for the diagnosis. Yes, but this picture can tell you that this patient can respond to fluids. Thank you so much. Next slide. Do you want to give fluids to this patient, my dear friends?
No.
This is a parasternal short axis view. So the view which I showed you before is a 4-chamber view. And this is a parasternal long axis view. Sorry, parasternal long axis view. What would you like to do with this patient? Would you like to give fluids to this patient, my dear friends?
No.
No. What do you think is happening here? What do you think is happening here?
Decrease in cardiac contractility.
Yes, thank you so much. So what do you want to give to this patient? You want to give something that will increase the contractility. So what would you give now?
Introvert.
Inotropic agent. What inotropic agent would you like to give the patient? What inotropic agent in your place where you're working would you like to give this to the patient?
Norepinephrine.
Inotropic. I'm talking about inotropic. Norepinephrine is not a bad answer. I would not say it's a wrong answer. But since my working diagnosis right now is cardiogenic shock, and I want to give an inotrope, there's a big difference between vasopressor and inotrope. So I want something to increase the contractility of the heart. So what inotrope would you choose? Dobutamine.
Isotretinoin.
Or dobutamine. Dobutamine. You can give dobutamine, or you can give levosimendan, or you can give milrinone. So these are the inotropic agents commonly used in ICU.
Mm-hmm.
The other thing that we talked about is using echo to look for responsiveness. So the most common method for looking for fluid responsiveness is actually IVC collapsibility in a non-intubated patient. Looking at this side, do you think should I give fluid to this patient? This patient is awake and we told him to take a sniff, and this is IVC. So what you see over here is his IVC. Do you want to give fluids to this patient? This IVC is more than 2.5 centimeters. Would you give fluid to this patient?
Yes.
Okay. What about this
What
picture?
is the normal IVC diameter?
It's around 2.5 to 3. What about this picture down? What about the picture down?
Yeah, we should give him fluid.
So look at the picture down. So there is a complete collapse of the IVC. That's more than 50% collapsibility of the IVC. So you would give fluid to the picture down. So the patient who has this scenario, rather than the picture up where the IVC is not collapsible. Is it clear?
Yes, clear.
Thank you. Now, on patients on mechanical ventilator, you cannot look at collapsibility because they are not actively breathing. They are passively breathing right now. So once they're passively breathing, you look for something called IVC distensibility. To look for IVC distensibility, you bring your P21 cardiac probe near to xiphosternum, get your IVC 3 centimeters away from the right atrium, press the M mode. Once you press the M mode, you get a picture above the dark grain picture where you will take the measurement. The same formula where I showed you the formula for pulse pressure variability. That is the maximum diameter minus the smallest diameter divided by the average of both of them into 100. If that number is more than 14%, that means the patient needs fluids. So remember again, in people who are not intubated, you look for IVC collapsibility. If it's more than 50% collapsible, you give them fluids. In patients who are mechanically ventilated and who are passively breathing, you look for IVC distensibility. Again, we need to take an extra class for ultrasound in ICU because we will lose time if I discuss more about it. So that's how what we look for fluid responsiveness in patients with while using the echo. There are other ways of looking for fluid responsive in echo, looking for something called VTI, velocity time integral. Because of constraints of time, I don't want to go detail into it, but inshallah, if you have time, we'll explain about it later. So advanced hemodynamic monitoring. So advanced hemodynamic monitoring, we look at the cardiac function. The 3 main reasons for monitoring cardiac function in shock are: number 1, identifying the type of shock, selecting the therapeutic intervention, and evaluating the patient's response to therapy. So I have used my ECG, I have used my pulse pressure variability, I have used my IVC, I have used my echo. Unfortunately, still I have not reached a diagnosis. I think the patient has combined shock. The patient might have distributive shock and cardiogenic shock. How will I know that? That's when I proceed for something called advanced hemodynamic monitoring. When do you want to use it? When the patient remains hypotensive despite adequate fluid resuscitation. When there is an ongoing evidence of global tissue hyperperfusion. Which biomarker will you use to tell you that there is a global tissue hyperperfusion in your ICU? What is a blood test that you always check?
Lactate level.
Lactate. Thank you so much, because lactate is the mirror of hyperperfusion. If you have a lactate of 6, that means it tells you that this patient has a global hyperperfusion. His aerobic oxidation has converted to anaerobic oxidation. His oxygen delivery has reduced from 1000 ml per minute to critical value of less than 300 ml per minute. That's why his lactate is high. Now, there are different methods of looking for cardiac output monitoring devices. The pulmonary thermodilution, that's your old pulmonary artery catheter, that's a Swan glance. Then there is something called the transpulmonary thermodilution method, where we use either PICO or a volume view. Volume view is from Edwards, PICO is from Philips. Transpulmonary indicator dilution, that's LITCO, where you use lithium. And the other echo and applied FIC breathing in partial CO2 breathing, bioimpedance and bioreactance. These are the advanced cardiac output monitoring devices. Let's just go quickly regarding the indications for pulmonary artery pressure monitoring. That's your Swan glance monitoring. We use it for defining shock of all types. We use it for assessment of cardiovascular function and response to therapy, for assessment of pulmonary status, for assessment of fluid requirement, for perioperative monitoring, which is very less routinely used recently. And these are the clinical applications of pulmonary artery catheter. So the Swan glance catheter, it is used for giving you the central venous pressure, the cardiac output, the right ventricular systolic ejection fraction, the systemic vascular resistance, everything. Remember one thing, the clinical applications of pulmonary artery catheter, the advantage, it provides a lot of hemodynamic monitoring. It gives a good sample site for SVA2, that's your mixed venous oxygen saturation. But what are the disadvantages? It's costly, it's invasive, there's a risk of arrhythmia because you're putting a catheter through the right atrium, right ventricle, left, and the pulmonary circulation. It can cause balloon rupture, pulmonary artery injury, and the mortality is high if there is an injury. So, unfortunately, this is what happened in the timeline of PA catheter. So, PA catheter was found by Swans and Gans, the colleagues. That's why it's named Swan Gans in 1970s. When it reached till 2005, people had mixed reactions about pulmonary catheter. But my dear colleagues, if you ask our colleague personally, we still need to use pulmonary catheter, especially when you have severe right heart failure. When you have severe right heart failure, pulmonary catheter still is the best and the gold standard for right heart failure, for diagnosing right heart failure. Let's talk about PICO. So PICO is pulse control cardiac output monitoring. They use transpulmonary thermodilation, whereas in pulmonary artery catheter they use pulmonary thermodilation. So basically, in PICO, what do you need? You need a central line and also you need an RP line. The most common site that they use for a central line is actually an IJ, a right IJ or a left IJ. That's what the most commonly used central line. And the most commonly used arterial line is a femoral arterial line. Basically, as you see in the picture, there's a central line and there's a femoral arterial line. These are connected to a thermostat and also connected to transducer. What we do, we take 20 ml of cold saline, inject the cold saline into the proximal part of the central line, proximal part, and we see the flow. Now, how do you see the flow? The flow, what you see right now is when you inject fluid, you see the fluid going to the right atrium, right ventricular, and the pulmonary circulation coming back to the left atrium, left ventricle, then it comes to the aorta, and at last it reaches the femoral artery. What do you expect the temperature of the fluid? So the beginning, the temperature of the fluid was cold. So when it reaches the femoral artery in the thermostat, what will be the temperature? Will it be more warmer or more cooler?
More war.
Yeah, exactly. Excellent, because it has passed to the pulmonary circulation, other circulation. Exactly. So what this machine does is that when you do this 3 times, the machine will take an average of the 3 measurements. The machine will plot the difference between the time against temperature against time, temperature against time. Once the machine captures the temperature against time graph by using special formulas, you will get something. So the mean transit time is the time when half of the indicator, which is indicator the fluid that you passed, has passed the point of detection in the arteries. So mean transit time is defined as the half of the indicator passing the point of detection in the artery, whereas the downslope time is the exponential downslope time of the thermodilution curve. So this is your mean transit time as I showed you here, and that's your downslope time. Now, why is it very crucial? This is very crucial because that's where you get your measurements. This fluid will give you transpulmonary thermodilution volumetric measurements. So it will give you how much is the volume that you're playing with in the heart. And as I mentioned, this formula is the Stewart-Hamilton algorithm. We don't want to learn this formula because it looks like a rocket science formula. We don't need to do this because the machine will calibrate according to the formula and give us the measurement. Now, what the machine does is that it will give you some measurements of your preload, some measurements of your cardiac contractility, and some measurements of your afterload. Now, that's what transpulmonary thermodilution does. Whereas the machine PICO works on 2 mechanisms. One is a transpulmonary thermodilution, that when I told you that you give saline and get the measurement. And the other technique in which it works is something called pulse contour analysis, where it gives you beat-to-beat analysis of the cardiac output and the stroke volume. How does it give that? The machine captures, because you know that I told you you need an arterial line. So the machine captures the arterial waveform from the monitor. It will look, this is called the area under curve. This area under curve, again through a formula, it will try to give you the measurement of real-time cardiac output and stroke volume. So PICO works under 2 mechanisms. One is transpulmonary thermodilution, where you need to do every shift, you need to look at the volume, so you need to do a measurement. And number 2, it will give you beat-to-beat stroke volume and cardiac output measurement by capturing the pulse contour analysis. So basically, this is what the PICO will give you. These are the measurements that the PICO will give you. So when you do a thermodilution parameters, it will give you the cardiac output. It will give you something called global end-diastolic volume index. That is your preload. That is the amount of blood present in 4 chambers of the heart after the end of diastole is global end-diastolic volume. This is a very crucial thing called extravascular length water index, which is the amount of fluid present in your lungs. This is very crucial when you're dealing with patients with ARDS. You want to know what's your extravascular length water index. What are the parameters that the pulse control parameter will give you? The cardiac output, the heart rate, the stroke volume variation, and the pulse pressure variation. So let's do a small test now. I have done the PICO for the patient and I have the value. Now I'm asking you, what is the current situation? So what among the 1, 2, 3, 4, 5 parameters you will choose to tell me about the current situation? What will you choose? What is the current situation? Whenever you want to look at the current situation, what are you looking for? The cardiac output. So cardiac output if it's low, cardiac output if it's high, cardiac output if it's low. So the current situation is the cardiac output. What is the preload? Which parameter among this will tell you is the preload?
Dr. Saib, I think I'm not sure if our colleague in Palestine has the PICO monitor. That's why I think.
Okay. Sorry. Okay, sorry. So
I want to hear from them. Yeah.
Okay. So global and diastolic volume is something that tells you about your preload. And will this patient's volume increase if will the volume increase cardiac output? That's when I look at something called stroke volume variability or pulse pressure variation. Are the lungs still dry? That's where when I use my extravascular length water index. And what is the afterload? Remember, the only parameter to tell you about the afterload is systemic vascular resistance. Lots of studies saying that if you measure the extravascular length water index, it will help you in correlating with the severity of ARDS. This is a decision tree that in all PICO machines, if you're using a PICO machine in your unit, which will be given to you as to follow it up and to decide your decision. What are the most common non-invasive cardiac output monitoring that we use in our ICU setting? We have something called the NICO, that's a non-calibrated, which is called the respiratory derived cardiac output monitoring system. So basically how it works is that it will use the partial rebreathing. So it will measure the cardiac output by using the CO2 that is removed from the system. So this is usually a very common non-invasive measurement used in the perioperative state. Also perioperative and preoperative. Most commonly it is used in the perioperative state, the NICO. But in our medical ICU, we don't usually use it because it has it is not of much use, especially when you're dealing with, frankly, septic shock. Bioimpedance is also a non-invasive thing. It's just you're attaching some pads and you're looking at the amplitude of voltage across the drugs. It's basically from the word itself, it will give you the cardiac output by looking at the bioimpedance, by looking at the changes in the level of the blood flow in the thoracic aorta. And something called bioreactance is again where they look at electrical currents transversing the chest and the cardiac output volume. So these are the very common non-invasive blood hemodynamic monitoring machines used in some parts of the ICU. But unfortunately, what are the problems with these things? When you're dealing with, in a medical ICU, when you're dealing with patients with frank septic shock, so when you are using patients with septic shock who are in 2 vasopressors, you cannot use this kind of non-invasive hemodynamic monitoring because it will not give you the best of the results. But still, in people with minimal shock, this can be used as a marker for hemodynamic monitoring. So this is the new thing called the tissue perfusion near infrared spectrometry, where the machine is attached to planar eminence, and it will give you your regional global perfusion, rather than giving you the global perfusion. These are the most common non-invasive measurement of things. Now let's go to a scenario. I think we have enough time for the scenario. We have a 56-year-old male who's type 2 diabetic, hypertensive, on lisinopril. He's on metformin, admitted to the accident emergency with history of productive cough, shortness of breath, and dizziness for 3 days. Okay. So what do you think is the problem? He's having productive cough, shortness of breath, and dizziness. His heart rate is 112. His blood pressure is 90/48. His saturation on room air is 90%. Patient is awake but drowsy. At this level, when this patient in front of you in the accident emergency, what is the best hemodynamic monitoring that you will start with? So this is an interactive question, so I want someone among you to answer this question, please, if you don't mind. The patient is having type 2. There is no wrong answer, please. Just imagine this patient is right now in your emergency and you're going to see this patient. And what will be the basic hemodynamic monitoring that you will start with this patient? Yeah.
From the monitor, we can clearly see that patient is tachycardic and
Yes.
he is hypotensive.
Yeah.
So he is in shock.
He's in shock.
Yeah.
Okay. When you look at the blood pressure, does it give you any rough idea what kind of shock are you dealing with? A rough idea, not a confirmed idea.
Hypovolemic. Hypovolemic. Distributive. Distributive. No, distributive.
Thank you, Doctor. Why you said distributive shock?
There's high pulse pressure and the diastolic is very low.
Thank you.
Comparing it to the systolic blood pressure.
Excellent. Thank you so much. So there is a wide pulse pressure, and the history also is telling you the patient is having productive cough, shortness of breath, and dizziness. So where is the source? Where do you think is the source?
Pneumonia. He's having sepsis.
Thank you so much. That's it. So that's why now we are going to pneumonia. We are going, I think the pneumonia is causing some kind of, we have not reached to the diagnosis of shock because shock is defined as, sepsis is defined as life-threatening end organ dysfunction due to dysregulated host response to infection. That's a new definition of sepsis. The new definition of sepsis is life-threatening end organ dysfunction due to dysregulated host response to infection. Septic shock is defined as sepsis not responding to fluid resuscitation, that is more than 30 ml per kg, or a persistent lactate more than 2 in spite of fluids. So we have not reached a shock right now, but this, let's consider this patient is going to shock. And you said that the patient's blood pressure is 90/48. If there's a wide pulse pressure, there is tachycardia. Remember, cardiac output equals heart rate times stroke volume. So the first thing, whenever there is a low cardiac output or whenever there's a problem in the cardiac output, the first thing to do to compensate for that is tachycardia. So tachycardia is because to compensate for the shock or for the sepsis. Excellent. So the best hemodynamic monitoring, as somebody mentioned, from the monitor itself, you know that the blood pressure is narrow, wide pulse pressure, is tachycardic. You can take an ECG, look at the ECG, make sure that there is no other shock that you're dealing with. What else that you can use right now in this patient? What you can use in this patient? I can give you 4 options. The patient doesn't have an artery line. So can you check for pulse pressure variability? No. But if you have an echo machine, can you use echo machine as a hemodynamic monitoring in this patient currently now? Or if you have an ultrasound, can you use it?
I think it won't be very helpful.
Why, Doctora? Bring the ultrasound, bring the echo probe, put the probe on the heart, look at the heart, look at the lungs. Isn't it helpful?
Dr. Saibu means the bedside focus. The
bedside focus. Bedside focus.
No, not the official echo.
Not the official echo. What about bedside focus? Will bedside focus help you in hemodynamic monitoring in this patient currently? Will
yes,
it help?
yes.
Thank you so much. So what do you look for focus here? Now, when you do the focus, what are you looking for? Okay, I did a parasternal long axis view. What will it tell you if in a parasternal long axis view? What all differential diagnosis you can remove from the system?
I will see cardiac contractility. It would be good, and he would be tachycardic.
Excellent.
And the ventricle wouldn't be very dilated or distended. There would be, because there's not enough cardiac return, venous return to the heart.
Okay. If it's causing sepsis, what else do you want to look at from your ultrasound?
I would look at the lung. I might find the source of infection in the lungs.
Excellent. Thank you so much. Now the same patient, you check the lactate, it is 5, and his blood pressure is reduced to 82/40. Now he's very drowsy, he's non-arousable, and the team decided to intubate him. Now he's intubated, he's in type 1 respiratory failure. He is on volume assist control with a rate of 18, tidal volume of 450. So he's getting almost 8 ml per kg of tidal volume. He's getting a PEEP of 10, FIT of 80 patient, PF ratio is less than 200. Like yesterday, remember Dr. Taslim mentioned to you about PEEP optimization and recruitment, it's all done. Now in this gentleman, what is the current hemodynamic monitoring that you will do? He has an arterial line now. How do you want to look for fluid responsiveness in this patient? He has an arterial line now. What do you look for? So the patient before, the same patient has changed now. He's intubated, he's on a ventilator, he's getting 8 ml per kg of tidal volume. His PF ratio is less than 200, unfortunately. So we did PEEP optimization and recruitment done. Now, what are the hemodynamic monitoring things that you will use in this patient? What all can we use? He has an arterial line. Can we check for pulse pressure variability to look for fluid responsiveness? Yes or no? Yes, we can look for pulse pressure variability because he has a pulse arterial line, so we can look for pulse pressure variability. Can we repeat the echo for him again? Yes, we can repeat the echo and look at his heart rate, cardiac contractility again. We can look at IVC variability. We can look at IVC distensibility. Put the probe, look at the IVC, see if the IVC is distensible. If it is more than 14% distensibility, then you can give the patient fluids. Now the same patient, unfortunately, because his PF ratio is less than 200, we deemed him as ARDS. Now I'm reducing the tidal volume to 4 ml per kg, and his MAP is less than 65. His lactate is going up 5.8. Now I'm in a problem. I'm in a big problem because in spite of my fluids, in spite of my noradrenaline, the lactate is going up. So now this is the time when I think, come on guys, there is something else cooking in this patient. Let's do one thing. Let's go for advanced hemodynamic monitoring. That's when I will use my PICO or pulmonary artery catheter, the Swan-Ganz catheterization, or any LITCO or anything, whatever is available in your ICU, to understand, is there only one shock or more than one shock? So this is how I do my hemodynamic monitoring. So basically, if the patient is not intubated, we can look for echo and the other parameters. Then if the patient is intubated, look at pulse pressure variability and again IVC distensibility. In spite of your fluid management, and if the patient is in ARDS management of ventilator strategy, you cannot look out for pulse pressure variability or IVC distensibility. So then you look for advanced hemodynamic monitoring like pulse pressure, like PICO or LITCO or anything. I'm sorry, because PICO is something a little bit alien to you. It would have been a little bit, but it's very good to know about PICO because that's something that most of us are using in most of the ICUs. So in conclusion, hemodynamic monitoring enables early detection of change in patients' conditions. New techniques provide reasonably good results and less invasive. Always correlate your readings, findings with clinical picture in order to provide the best treatment options. So I can tell you one thing, my difference. Even if I have the PICO, and if I don't know how to interpret the PICO, then there is no use in using the PICO. I agree with the fact that always the best and the most sustainable way of hemodynamic monitoring is clinical examination of the patient. Look at the pulse pressure, look at the lactate, look at the echo, do an echo of the patient. Look at how your arterial swing is there, if you have an arterial line, if it's high swing or low swing. Put everything in a puzzle, be like Sherlock Holmes. Bring everything in a puzzle, put the puzzle into right. Bring the lactate, bring the CVP. I remember I told you CVP is a static parameter, but still don't omit CVP. If you have a CVP, bring the CVP, bring the pulse pressure variability, bring everything together and then come to a conclusion. Never come to a conclusion from one measurement. This is a snapshot of how to treat shock. Remember, when you treat shock, your main treatment of shock is to improve the oxygen delivery and reduce the oxygen consumption. So whatever reduce the oxygen delivery, you have to improve it. So oxygen delivery depends on saturation, oxygen delivery depends on hemoglobin, oxygen delivery depends on cardiac output. So this is something that we should always remember. Whereas things which will increase the oxygen consumption. We need to reduce it. For example, the patient is tachypnea or increased work of breathing, intubate. If the patient is agitated, delirious, sedate the patient. If the patient is having fever, give him antibiotics so that you reduce the oxygen consumption. Because as I told you, it's like a weighing machine. You have to increase your oxygen delivery and reduce your oxygen consumption. Then only you can treat shock. Thank you so much.
Thank you very much, Dr. Saibo. We'll give like 30 seconds. If anyone have a question, then we'll go for the second lecture of Dr. Ahmed. I think we have one comment. They are saying thank you for Dr. Saibo in the comments for this interactive lecture. It was really a good and amazing lecture. Thank you, Dr. Saibo, again.
Thank you so much. Thank you.
Yeah, 1 minute advice for our colleague in Palestine. They are now fighting the COVID. Just 1 minute advice from your experience about the hemodynamic.
While you're fighting the COVID, if you ask me which is the best hemodynamic monitoring used in COVID, I don't have a real answer to that. There are a lot of parameters, but as I told you, your basic instincts is very important. Basic examination should never be weighed down whenever you go for hemodynamic monitoring. As I mentioned before, I think echo should be your ultrasound should be your best friend in ICU. The ultrasound, if you learn how to do the ultrasound, it will teach you a lot of things. It will help you in diagnosis of the shock. It will help you in following up the fluid responsive in shock. So try to learn ultrasound from your colleagues, and inshallah, we can arrange ultrasound session for you through webinar. If Kandil can arrange later, we can have sessions for ultrasound for you, for our colleagues in Gaza. Inshallah, we can do that. So whatever is available in your ICU, use that. I would never say that PICO is the best. You should buy PICO in your ICU. No, I'm not going to. I'm not going to be a champion for PICO. No, as I mentioned to you, whatever things are available in your ICU, utilize them, please. So use your RTL line, check the RTL waveform. That waveform will give you a rough idea about the contractility and your of your heart, everything. Thank you so much.
Thank you, Dr. Saibo. Thank you for your times and being with us today. Hopefully, we'll have you again in the future, inshallah. Thank you very much.
Thank you so much.
Thank you. Now we'll start with the second lecture with Dr. Ahmed Abdel Salam. He's a senior consultant in medical ICU, Hamad General Hospital. He's holding a board degree in neurocritical care from the United States. He's one of the experts in this field in the region, I guess, in the Middle East. So managing patient sedation and agitation is very important as a part of comprehensive management for the patient in ICU. So Dr. Ahmed, can you please start?
Assalamu alaikum, Masa al Khair, everyone. Thank you for giving me this opportunity to help you in these difficult times. Actually, it will be a very informal talk, and you're welcome to interrupt, ask question anytime. Sedation is not like straightforward 1, 2, 3, like what just Dr. Saibo went over hemodynamics. It's depends where you work, what drug is available for you. A lot of things decides what kind of sedation, what depth of sedation you should use. We'll try to cover the basic, and at the end, if you have any specific question about any case or any scenario you've been through and you have you're not sure about what you're doing, we can always discuss it. Bismillah. So what we're going to do in the next 40 minutes or 45 minutes, we'll just highlight what's sedation, talk about how we monitor sedated patients, what's the best option. We will highlight the commonly used drugs we use in ICU. We will not be able to cover everything, but we will cover 4 or 5 medications we use day in, day out. We'll talk about a little bit about pharmacokinetics and dynamics of these drugs. We'll do a little bit of literature review in between when we're talking about different medications and which one is better than the other. We will also touch on the guidelines, mostly the North American guidelines. And we will highlight one strategy, how you wean off your sedation. Your patient is sedated for a few days. What would be the best option to take off these medications? And we will conclude by delirium, which is nowadays is the what we call monster in the ICU. So sedation, it came from a Latin word called sedar, or means either means comfort or allaying of fear. Any patient in the ICU, either he is sedated or he having some sort of analgesia or both, or sometimes we give a muscle relaxant. But if you look at any ICU at any given time, probably 80 or 90% of their patients are sedated or in pain medications or both. So what we try to do in the ICU, we try to make them comfortable, reduce their agitation by administration of these sedative medications. It is one of the most difficult and challenging management in the ICU. You always try to keep your patient not deeply sedated and not awake, not in pain, not agitated. And this makes a big challenge for you, for your nurses, for everyone working with you. Why? Because your patient is not able to communicate with you, is not able to tell you how he feels and what he needs, because your patient is intubated or confused or delirious, whatever the pathology is. So that will become as a barrier between you and your patient and make achieving the goal of sedation challenging and difficult. So imagine this is a patient in the ICU. He came in with acute medical or surgical problem, whatever the reason for admission in the ICU. He have a bunch of chronic medical problems. We put him in mechanical ventilation most of the time. We do invasive procedures on them. In a few days, he will acquire something from the hospital like COTI or VAB. And don't forget about the ICU environment, small, dark room, a nurse coming in and out with dressed completely hardly. They can see their faces, especially nowadays with the COVID running around. What they will end up with a lot of anxiety and agitation, and that will complicate what's their problem they started with. So what we do for them, we give them medications, trying to control this anxiety and agitation. This medication itself can cause anxiety and agitation, and you will end up in this vicious cycle. What we learned today is how to address this issue and how to basically try to keep a balance between keeping our patient comfortable and having the right dose of the right medications. So why we need sedation in the ICU? We need sedation for a lot of reasons. I'm going to highlight a few of them here. Making my patient comfortable is the main reason, trying to optimize their oxygenation if they are an ARDS or a COVID patient who's just been intubated and had trouble oxygenating him. Of course, prevent the asynchronicity between the patient and the ventilator, which is a major problem we have in the ICU. If I want to intervene between lines, doing any tests, any studies, I want to make sure my patient is comfortable there. Try to help him to sleep at night, which is a major issue in ICU because of the patient loses their REM sleep. And of course, we want to lower the stress-related response, the neuroendocrine response, the release of all these hormones and cytokines, which basically complicates the situation of my patient. What's the ideal sedation? If you ask me what would be the ideal sedation for any patient, or an ideal sedative, or ideal drug I should give, a rapid onset of action. It works immediately as soon as I give it so that my patient is comfortable. It's a short acting, so it should not sit in his body, on his system for hours or days. So whenever I stop it, I wake up my patient and I can assess him. Easily titratable, so my nurse will not struggle to adjust or achieve the target sedation scale or target dose for this medication. Should have no drug interaction. It should have no side effects. had no active metabolites or toxic metabolites, and it should be cheap. I can afford it. So that would be the ideal sedation. Do we have ideal sedation? Do you guys have ideal sedation in your ICUs? Probably not. There's no drugs which fits all these criteria. Am I still online?
Yes, Dr. Ahmed, you are online. Yes.
Dr. Mohammed?
Yes, yes.
Sorry, I'm not seeing any pictures here. Okay, so art of sedation, or how we should achieve this sedation. We should not under-sedate our patient, and we should not over-sedate our patient. Let me just put the big screen here so we can go step by step. Yeah, so we should not under-sedate our patient, because under-sedating the patient will increase their anxiety and awareness of the surrounding. And if your patient aware of that ventilator, that dark room, that all these lines and drips, you will become more anxious, and we go through the vicious cycle I just mentioned earlier. They will start fighting the ventilator and fighting whatever you're trying to do to them. They probably will self-extubate themselves. That will compromise your oxygenation there. That will cause more strain on the cardiovascular system, definitely. And they will end up more with post-traumatic disorders. That's if we under-sedate our patient. How about if we over-sedate our patient? What would happen? They will spend more time on mechanical ventilation and will have difficulty in weaning them off. That's the same thing, prolonged weaning. They will end up with delirium, because most of the medications we give here nowadays, it will cause some sort of delirium, and we will highlight the delirium at the end of this talk. They will have withdrawal symptoms of these drugs because you gave it for a long time, and they will develop tachyphylaxis and tolerance to these medications. How we assess sedation, if you look at the, if you type sedation assessment or scales in Google engine, you will end up like maybe by 15 scales there. And you'll be literally confused which one I should use. I think you should adapt one of these two, the first two. Either you do a Ramsey sedation scale or Richmond. Richmond is more validated. Most of the studies done with Richmond agitation scale. It's easy to learn it. It's easy for your nurses to adapt it, and you can scale your patient in no time. And I'll just highlight very quickly some of these scales here. You see how complicated this modified Glasgow Coma scale ends up with 18 points here. And if you look at the details of this scale, it's really really complicated. You need to have a degree to run this scale. Motor activity assessment, sedation agitation. Ramsey comes second to the Richmond one. Ramsey is very simple, goes from 1 to 6. 1 is anxious and fighting you, the patient. And 6, basically, he have no response at all. He's deeply sedated. This is a small study done on Ramsey sedation scale. And if you look here, this is where you want your patient: cooperative, oriented, and tranquil. And look how many people self-extubated here. It's pretty high. This is the highest number of self-extubation in these patients. So the most validated scale is the Richmond agitation scale. And if you look at the colors here, if your patient in the red color, that means he's not well sedated, he's combative, or he's very agitated, or he's fighting, or he's restless. If he is on the negative side, that means he's very sleepy, or you overdoing it with your sedation. This is where your patient should be at 0. And for this part is just observation, looking at your patient, and you can assess for these 4 variables here. But for the for the negative part, which is, that means you're giving too much drugs, you're looking at your patient, and basically just by eye contact, if he's spending more than 10 seconds looking at you, that's -1, less than 10 seconds is -2, and so on and so forth. But ideally it should be around 0, maybe 1, maybe -1. So if you able to achieve this goal here, you've done a good job for your patient. By the way, you can stop me, interrupt me anytime if you have a question. A quick question about the, quick mention of the PIS bispectral index. This kind of monitoring we use in paralyzed patient, and I'm sure they used in your and they used in the OR. Basically, it's 3 leads EEG, and the number and this EEG will be changed to a numerical number. This numerical number goes from 0 to 100. Me and you were not able to read EEG, so we'll look at the number. That makes our life easier. And your patient should be around between 40 and 60, especially if they're paralyzed, so you make sure they are well sedated. I don't know if it's available for you or not. So this is what the guidelines says about monitoring and depth of sedation. Sedation medications to be titrated mainly to a light level of sedation. They did not specify what level, but again, if you're using Richmond, it should be 0 plus or minus 1. Light sedation might have some stress, physiological stress response, but it have a better outcome than having your patient sleeping the whole day. They recommend RASS, Richmond Agitation Sedation Scale. They're saying it's the most validated and reliable sedation assessment tool. And these things in practice are the level of evidence, A, B, and C. B stands for randomized controlled trial, based on the randomized controlled trials. And there's no recommendation for any other, like the PIS or the other scales like a brain stimulation or nerve conduction or whatever. Okay, just to this slide to make everyone happy here, whoever watching us, this is the prevalence of use of sedation scales in different countries there. Look at these countries like where we are, Sweden. They have a 0 infant mortality rate. They have the best health service in the world, but they hardly use any, 50% of, less than 50% of their ICUs using sedation scale. So we're done with the sedation scale. Any question there? Okay. So how we approach this patient? My patient is anxious, agitated. What options we have? How can I manage these patients? We can do non-pharmacological approach, and unfortunately, none of us is doing it. Wherever you practice in Qatar or in the States or in where you are now. So what should we do? We should have a good nursing care. Good nursing care means the nurse walks in, explains to the patient what she's doing, what she's about to do. I'm turning you, you might feel pain here. Just tell me if you have any problem there. I'm gonna take a blood from you. So this is what we meant by communication and good nursing care. And that releases a lot of burden there on this and this problem. Family support, if you have a family who can hang on with the patient, if your rules or regulations allows to be a family members in the ICU, that would make life easier for everyone, and especially for the patient. Explanation and reassurance, again, same goes to back to communication. And environment. Our ICU rooms are, again, small, dark, no windows. You don't know the patient if there is it's a day or night, and he spends days, sometimes weeks. He doesn't know what's going on there. He sleeps anytime, wakes up anytime. If you make the right environment for them, just the daytime, you open the window, a little bit of light there, maybe a TV, maybe some whatever he enjoys. You just make sure it's there for him. That will make him more comfortable and make your life easier too. But unfortunately, we don't do much of this here. We always jump on the medications, and the medications comes in different forms, different colors. Most commonly used medications, benzodiazepines, midazolam, lorazepam, diazepam. We hardly use diazepam now. Would be nice to know what medications you have there in Gaza. Do you know, Dr. Muhammad, what medications you have there?
I think they have benzodiazepine, they have propofol, ketamine, thiomenton, I'm not sure. They really use morphine. I think they are fentanyl also. Anyone can unmute and tell us Dr. Muhammad Saleh.
We had midazolam, diazepam, propofol, ketamine, thiopental, morphine, fentanyl, and haloperidol. Just.
You have the, do you have the
No, we haven't. We haven't.
No.
We haven't. We haven't.
No, we haven't.
Okay, all right.
Even
Because
fentanyl.
this is my favorite, and I thought this is with the least side, but this is expensive as well, unfortunately. All right, we'll highlight some of these medications here. Again, benzodiazepines, the midazolam and lorazepam, these are the most commonly used. Diazepam is common off the shelf now. It's not as, we don't use it as commonly as before, maybe in pediatric more. Anesthetics, mostly we use propofol and ketamine. Some places they use thiopentone. Again, this is a horrible long-acting medication, and just keeps your patient in coma for days sometimes. You can use opiates if you have someone in kind of light sedation, someone in pain, but most of the time you need to use combination of both sedative and analgesic. And again, the alpha-2 agonists, dexmedetomidine and clonidine. Clonidine, probably you guys have clonidine. We use clonidine here for sedation sometimes. It's cheap, but there is problems with it, as you all know. And butyrophenones, the haloperidol, nowadays we use mostly to try to control delirious patients. We'll go over these groups one by one. And again, if you have any questions, please raise your hand. So before we talk about different classes, just remember all sedatives share the following problems. And when I say problems, all medications we give in the ICU, there is side effects there. So we have to weigh the benefit and the harm or the side effects, and then we make a decision. That one size does not fit everyone. Some people, they like their benzos, and some people, they crash on benzos, and you have to try something lighter. So it varies from patient to patient, depending on your pathology, the age, what organ are failing. A lot of things this makes help you to make a decision. So all of these medications accumulates if you give them for a long period, and they will make your life difficult when you try to wean them off, because they develop tolerance, dependence, again, tachyphylaxis. All of these medication, unfortunately, will lead to some degree of delirium. Some, like benzodiazepines, 80% of your patient will end up with delirium. And as we all know, delirium increases your mortality and morbidity. They have some effect in the circulation. They all can cause hypotension, tachycardia. So you have to deal with that. Tolerance in use and withdrawal in cessation, as I just explained. And unfortunately, none of these helps the patient to sleep. We assume if we give benzodiazepines like a dose of midazolam at night, my patient will sleep. He will sleep. Of course, he will go in a coma, but he will not have the ideal REM sleep. And all of them have, of course, with different degree effect on the intestinal motility. So I'll start with the benzodiazepines, and benzodiazepines, the most famous one is, just sorry, a few words about benzodiazepines. They work by inhibition of the chloride channels and basically inhibits the action potential. This is the mechanism of action. They have a high volume of distribution. That means it takes longer to get out of the body. They cause antegrade amnesia and have no significant analgesic effect. So whenever you give benzodiazepines, make sure you give pain medications with them. And that's what we will see later. And there was this anticonvulsant effect, we all know that. If you have someone who's old, having liver failure or renal failure, someone who's alcoholic, someone who's using other or in a regular other sedatives, that will, is someone trying to say something? Okay, so if you have any of these factors that might alter the way you dose these medications. For example, if you have someone with, again, liver failure, that will reduce the clearance of these benzodiazepines, and patient will be sedated for a longer time even after you stop the medications, and making the weaning process either from mechanical ventilation or from the medication itself challenging. All of them cause hypotension, as I mentioned earlier. Okay, so one of the most commonly used one is the midazolam or Versed, and you said you have it there. It has a high lipid solubility. It works within minutes. It will accumulate in hepatic and renal failure and make longer half-life, or it will have a longer half-life. And if you're using one of these medications that will inhibit the metabolism of the cytochrome 450 and will make the half-life much longer if they're patient in propofol, diltiazem, or iconazoles. The second one in line is the lorazepam, what's the Ativan. It has less lipid solubility. It works again within minutes. It has a longer half-life. And we always have to pay attention to propylene glycol toxicity. It's the vehicle for the drug. If you're using a high doses, 1 milligram per kg per day, if you're using this dose for more than 7 days, there will be a high risk of this toxicity. And your patient will end up with a severe lactic acidosis, of course, leading to an iron gap metabolic acidosis. And you can monitor that by, if you use it for a long time, you can do a frequent measurement of the serum osmolality. When it starts going up, that means you're in trouble or your patient in trouble, and you have to think about alternative sedative. Here is a small study comparing both lorazepam and midazolam. And if you look carefully here, with its favors lorazepam, basically, more times patient satisfied with the sedation comparing with the midazolam. And cost, look at the cost, the difference in the cost between both. This is $1 per day. It's about $7 for the lorazepam. It is 10 times more for the midazolam. It's more expensive. And that's why in the guidelines, they say in midazolam, you should use only for a short term, like for a procedure or someone you need to intubate, and should not be used for a longer period of time. Instead, you should use lorazepam for when you wanted to put someone to sleep for a longer time. And hopefully that's what you do there, because that would save you a lot of money. How about propofol? Michael Jackson medications. So it works by activation of GABA receptors, and at the same time it increases the extracellular dopamine. It has a sedative and amnesic effect, but the amnesia is less than benzodiazepine if you compare it with benzodiazepines. It works very quick, as we all know. Within a minute or two, your patient is gone, deep coma, sleep, sometimes stop breathing. That's why we should not use it in non-intubated patients, always in intubated patients. It's eliminated by the liver, conjugated in the liver to inactive compound. So if you have a liver, it hardly touched or pharmacokinetics hardly changed by any renal or hepatic impairment unless your liver is, for example, in a cirrhotic patient, someone who has basically no liver, then you're in trouble. Good thing about it, it reduces airway resistance. It reduces cerebral blood flow. It reduces the ICP. And basically it reduces the brain metabolic or oxygen consumption. Indirectly reduces the other three. And it's faster to wean off your patient from mechanical ventilation if you're using propofol comparing if you're using benzodiazepines, and for the above reasons. Problems, every drug has a problem, as I mentioned earlier. It suppresses the sympathetic activity, causing myocardial depression and peripheral vasodilatation. That means more hypotension and more cardiac problems in someone who have already cardiac issues. If you use it for a long time means the cutoff done or given by the Critical Care Society is more than 48 hours. Though we use it longer than this, but we carry the risk there. There is a risk, so we have to monitor a few things, as I'll mention later on. It will be associated with lactic acidosis of bradycardia, or we call the BRIS syndrome, or propofol-related infusion syndrome. It does not provide analgesia. Definitely, you need to give analgesics when you give an propofol. And it increases serum triglycerides. So you have to watch for triglyceride level for someone with already high lipid profile, or someone with a pancreatitis, or someone you give it for a long period of time, then you have to watch for triglycerides. It causes pancreatitis and causes zinc depletion in a long-term use. It requires a dedicated IV access. This is when you give it in a continuous infusion. If you give it boluses, doesn't matter. But if you give it continuous infusion, it interacts with a lot of medications. So most places or most nurses will have a dedicated IV access for the propofol. And this is basically the propofol infusion syndrome, or toxicity de PRIS. Just there's a lot of big names there. We're not going to worry about it, but inhibits basically the entry of short, medium chain and long chain fatty acids into the mitochondria, which would impair the energy production and causes the lactic acidosis will shift to the anaerobic and causes severe metabolic acidosis, acute renal failure, and cardiac depression. So we should watch for this. It has a high mortality rate. If your patient goes in propofol infusion syndrome, the mortality rate is 80%, 80. That's pretty high. That means 8 out of 10 patients will die. So what's propofol infusion syndrome one more time? It will be a picture of rhabdomyolysis, metabolic acidosis, renal failure, and of course, acute heart failure. If you use it for a long time, at a high dose, if your patient have high Apache score, head injury and subarachnoid hemorrhage, I have no idea why, but it's been listed. If your patient is status epilepticus, if he's in catecholamine infusion or glucocorticoids, if he fits any of these criteria, you have to keep an eye on this propofol infusion syndrome, and you have. It's much better if you just think about a different sedative for patient with this kind of pathology. So what the guidelines says or recommends about propofol, they're saying it's the preferred for if a patient you think you should wake every day to assess their neurological stats. For example, someone with brain bleed, subarachnoid hemorrhage, stroke patient intubated for any reason, someone you want to wake up every day and you want to assess their neurological stats. Propofol will be the best option here. And you have to watch this, and you have to watch for triglycerides, as we mentioned earlier. So which one is better? Should we use midazolam or propofol? We're just going to go over, I think, a couple of studies here just to highlight this issue. If you look at the study, it's a small one, but if you look at the two axes here, one is for midazolam and one for propofol, and the first graph is saying it have the same efficacy. They're both go on the same line. Actually, this is I'm sorry, take it back. This is a big study. This is a meta-analysis, actually. Each circle represented study. The bigger the study, the bigger the circle. There's a few results skewed here and there, but the general trend here, they just got the same axis for efficacy, how good they are in sedating your patient. Duration of adequate sedation, exactly the same, both of them. So for sedation-wise, they're good. They works, they're very well. But if you look at the time of weaning, when you decide to wean your patient off the ventilator, which one is faster? Propofol will be weaned faster. Look at here. It's 250 minutes. Here is up to 450 minutes. So that's where you have the challenge for the reasons we mentioned earlier, because of the accumulation of metabolic products and the effect of organ failure on the metabolism of the benzodiazepines. Now, this is my favorite drug. Sorry you didn't have it there, but you should learn about it. It's a kind of expensive comparing with the other medications, but it is the best medication you can use to make your patient comfortable. It's basically works the same mechanism like clonidine, but it's 7 times stronger than clonidine. It works in the alpha-2 central receptors in the brain. Look at this. It's a sedative. It causes amnesia. It gets rid of the anxiety, and it's a sympatholytic. Gets rid of the tachycardia, the hypertension, the sweating, all the sympathomimetic effects of being in the ICU, of being in other medications. Basically it controls them. They have a short half-life. It's about 2 hours at the max. It's secreted by glycerolidation in the liver. So if you have a bad liver with more than 50% reduction in the liver function, then you'll be running in trouble, or your patient running in trouble. It's a high protein bound. It does not alter the sleep cycle, or this is what we believe. Based on sleep studies, based on EEG, they did not find it. It does not interfere with the REM sleep. So again, that's a beautiful thing. That's a good thing about this Precedex. This study comparing this nice drug, the dexmedetomidine and midazolam in critically ill patient. It's a big study, actually. It's a double-blinded, randomized controlled study, about 68 centers worldwide, 5 countries. They recruited surgical and medical patients, about 375, as you see there. They did it on patients who are mechanical ventilation more than 24 hours, and they used the RAS and CAM ICU. CAM ICU, this is what we use to assess for delirium in the ICU. Now look at this. People on the dexmedetomidine here, they get extubated faster comparing with the people on benzodiazepines. And if you look at this graph here, people who are on midazolam, they stayed longer time in the ICU and in the hospital. So it reduces your length of stay and makes your patient extubated faster. This is definitely a significant p-value less than 0.05, and this is more of trend, but again, it is bonus. Faster extubation and fewer days in the ICU. And here is the effect on delirium. So the black one represents the dexmedetomidine, the gray one represented the midazolam, and if you compare people who have a delirium here, they did basically what they did the ICU CAM score every day during the ICU stay, and every day you have less people with delirium in the Precedex group. A similar study comparing the effect of both drugs on the acute brain dysfunction, or what we call nowadays delirium. Again, a less delirium in the dexmedetomidine group comparing with the lorazepam. And faster in achieving your sedation scale, the RAS scale, in the dexmedetomidine group comparing with the lorazepam. And I believe this is because these patients are able to communicate with you, if not verbally, because they're intubated, they can use their hands, they can write, because they're still awake, does not cause sleep, does not make your patient in a coma. We're done with the alpha-2, and we'll just highlight quickly the ketamine. You said you have ketamine there. So ketamine works on the NMDA and opiate receptors. That means it causes sedation and analgesia. It causes what we call dissociative anesthesia, and I'm sure you've seen a lot of cases with this in this category here. It works very fast, within a minute. It has a very short half-life, and this is why we give it in continuous infusion. It has a positive inotropic action and causes vasoconstriction. It increases cerebral blood flow, and that could be an issue or problem if you're trying to sedate someone with a raised ICP or someone with brain bleed, and you worry about their brain swelling. It causes a bronchodilator, and this is people, that's why we like to use an asthmatic patient. We intubate them with them in ketamine because bronchodilator, dilatory effector, the inhibition of endothelial nitric oxide. it reduces analgesia in general or morphine consumption because it has opiate receptor effect and has no effect on the bowel motility. So all this being said, what should we do? Which drug should we pick? What would be the best option for us? What's our goal? Our goal to keep our patient calm, comfortable, pain-free, and they're able to sleep, right? This is what's our goal for any patient in the ICU. And they should be able to tolerate any organ support we plan for, like if you decide to put someone in inverse ratio ventilation, they should be able to, because it's very uncomfortable, right? So should be appropriately sedated for that kind of intervention. Remember, no patient should be paralyzed and awake. So if you paralyze someone, they should be in 2 other medications. They should be fully sedated and they should be pain-free because it is a horrible experience. And using sedative does not mean we have to keep our patients sleeping all the time. Unfortunately, this is the trend. This is what we do. We just make sure patient is in a deep coma so they can work with the ventilator and the nurses can do their jobs. But that should not be the case, as we mentioned earlier. Before you start using your medications, always remember, or increasing the dose of your medications, remember to consider non-pharmacological measures. They're pretty helpful there. Remove any source of physical discomfort. Increasing the dose. So for example, someone on 0.1 mic of midazolam per kg per minute, and suddenly the nurse calls you and say, hey, he's becoming agitated or becoming not comfortable. So before you start increasing the dose, you ask yourself why he's doing that. Does he have a, most of the time it's related to his clinical condition, some sort of deterioration in his clinical condition. So you have to pay attention to these days. Always remember to bolus before you increase your infusion, because if you just increase your infusion infusion rate before you bolus, that if you know, as you know, you need 5 half-lives to achieve your therapeutic goal. And if you don't bolus, that will not increase in the infusion will not work for you immediately. You have to wait for another, whatever the half-life of that drug is. So you have to always remind your nurses when you order or you ask them to increase the infusion rate because your patient is uncomfortable, make sure you tell them to bolus before you increase the infusion rate. When sedation has been stopped, night sleep well, pitfall, because there will be a rebound of rapid eye movement sleep. So your patient would be sleepy a lot of times, a lot of hours. And combination, that's the best statement actually. Combination of sedatives that act via different mechanisms are more effective than a single agent at a high dose. So if you find yourself increasing the dose of that midazolam and hitting the maximum dose, reconsider your option, maybe adding a pain medication or maybe adding a different sedative works in a different mechanism, maybe will help you to achieve your goals better than going up in that medication. Okay, so what the guidelines says, they're saying we suggest the sedation strategy using non-benzodiazepines. So if you have something else like a propofol with all the precautions we just mentioned, you have to consider it. If you have, again, the dexmedetomidine, that would be your best option here. They prefer non-benzodiazepines over benzodiazepines because that will improve the outcome, reduce the risk of delirium, shorten the days on the ventilator, shorten the days in the ICU or in the hospital in general, and of course reduces the post-traumatic disorders after discharge from the ICU. So how we can achieve these goals? One, try to use intermittent other than continuous infusion of these medications. So given boluses, frequent boluses, if you have enough, of course, nursing staff, if you're not busy, your nurse is not busy, try to advise them to give boluses other than just starting someone in a hefty dose of benzodiazepines and walk away. that will improve your outcome, and I'll show you a study in a minute. This will be a slide here. And this is a small study comparing continuous infusion, intravenous sedation with someone who have intermittent doses. And if you see the probability of remaining in mechanical ventilation, the big difference between both arms here. So intermittent doses is superior to continuous infusion, if you can do that. So you'll ask me for how long we're going to do it for. 5 days, 7 days, we keep giving intermittent doses? Of course not. So you give it for like 3, 4, 5, 6 doses. If you keep doing it and you don't have the labor, your nurses are busy, you don't have enough nurses there, you're busy with someone else, or it's a very busy ICU and they cannot do that, then you start infusion. But if you have a quiet day, if you have enough nursing staff there and they can do it, that would improve your outcome. But always keep a balance. So step or option or advice number 2, try combine sedation and analgesia at the same time. And if you do that, based on this study, it will improve your outcome. Look at this. So this is comparing 2 arms. One, just midazolam alone. Can you see the cursor here, Muhammad? Can you see my cursor?
Yeah.
Okay, good. So here is the midazolam alone, and here's with analgesic. I believe they used morphine here. So asynchrony is less with the ventilator. These are intubated patients. Time to sedate was faster if you use both, and costs or money spent on sedation is less. And it's a very significant p-value for the first one, and for the last 2, it's just a trend. It's also a lower or a faster or easier, let's say easier for your nurses to achieve their sedation scale, target sedation scale, if they use analgesic and sedative at the same time. And if you look at the side effects between the 2 arms, it's more or less the same. The risk of hypotension, hypoventilation, ALS, or a coma is more or less the same. If you look at this non-significant p-value, it's the same side effect profile if you use a sedative alone or use a sedative with analgesic. Now, what's the third thing you can do? You can do a sedation vacation. What sedation vacation is? Basically, you stop your sedatives every morning when you see your patient. See how much they need. Do they need this hefty dose I'm giving to them? Can they go by just boluses other than continuous infusion? Do they need the sedation at all? So that's very important. Unfortunately, we start someone in sedation, and the time we decide to stop the sedation is the time when we want to extubate them. Maybe a day, maybe a week, maybe 2 weeks, 3 weeks. That's not the right practice. So every morning you walk into that room, ask yourself, do I need to continue the sedation? And this is evidence-based based on this study done by Chris. It's a very famous study. If you look at the days of mechanical ventilation, if you do daily interruption of the sedation, less days in mechanical ventilation, and less days in the ICU or in the hospital altogether. It will also allow better assessment for patient sedative need. Maybe he doesn't need that much of sedation. Of course, definitely will reduce the bioaccumulation of this, whatever medication you are using. And I just told you how bad these benzodiazepines we use. It reduces the risk of, or the incidence and risk of post-traumatic stress disorder and other complications in the ICU. The fourth strategy is what we call daily trials of SAT and SBT. SAT stands for Spontaneous Awakening Trial, and SBT, as you know, Spontaneous Breathing Trial. So again, you stop the sedation, you wake them up. If they're good, you give them spontaneous breathing trial. Of course, you will not wake up someone with ARDS and having a PF ratio of 60 or 70 or even 120. So you have to assess. see if he's improving, his whatever the reason you intubated him for is resolving or has resolved. You have to look at the certain criteria, which I will highlight now. If they fit these criteria, wake them up. If they're not, just walk away. And this is based on a big study done by Timothy here. And I think a lot of ICUs now adapting this kind of protocol in their ICUs. They basically leave it to their either respiratory therapist or to their nurses. They do the assessment, and by the time the physician shows up, their decision already made. So you have I'm going to go over the protocol they used here, and this is the one adapted by different ICUs. So you have a patient mechanical ventilation. He's been there for 3-4 days or whatever the time is. They're improving, they're getting better, and you decide, okay, should we see if they're fit in this spontaneous awakening trial? So first of all, you have to screen for it. Does my patient fits this trial? And by screening means my patient is not agitated, he's not on paralytics, he's not seizing, he doesn't have a cardiac problems, he have a normal ICP, and he does not have any alcohol history here. So my patient fits this, he passes all these screening checklist. Pass. We will perform the spontaneous awakening trial, means I will hold all of his sedatives and analgesic. He did well, he did not have a problem. I will check for the spontaneous breathing trial safety screen again. So he's awake, but he's still in the ventilator. And I'm gonna see if he fits or if he's good for spontaneous awakening at a breathing trial or not. Here's the checklist. So he's awake, his saturation more than 88%. He's not in he's in a minimum what we call vent settings. His PB is less than 8 and his FiO2 is less than 50%. He's in no pressors, or maybe a small dose of, most people they say 5 mics of dopamine is acceptable to extubate someone. And he have no problems with, he's not distressed respiratory wise. He's good there. I will perform the spontaneous breathing trial, and if he passes, I will extubate my patient. So this is the bright side, this is the good side, everything is done, and everyone is happy there. So how about if I do the spontaneous awakening trial safety screen? He does well, and I perform, here again, I hold my sedation, and my patient fails. Why? Because he became anxious, he's agitated, looks like he's in pain, he's breathing too fast, he dropped his oxygen saturation, or he started having some cardiac issue. What should I do? Oop. They recommend to cut down his sedation by 50%, go back, put him to sleep again, and you try next day. So how about if I did the safety check? He did well. I woke him up, he did well. Then I put him in spontaneous, I screened for a spontaneous breathing trial well. Once I put him in a spontaneous breathing trial, he fails. He became tachypnic again, or his breathing is very slow, I'm not happy with, because probably the effect of the medications, or becoming confused, desaturates, respiratory distress, or cardiac issue. So what should I do? Oop, again. I'll put him back on full ventilatory support, and I'll wait for 24 hours, and I'll go over the same cycle again. It looks very long, right? Just because I'm trying to be very slow and explain it. But if you practice it, if you do it 1 to 10 times, 50 times with your nurses, will become second nature, and it will be kind of evidence-based and a safe way of approaching these patients on these medications and people who are in mechanical ventilation. These are the outcome of this study. They followed this protocol, and this is what they ended up. They ended up with less time on mechanical ventilation. If this is the intervention group, this is the control group. Intervention means they followed the protocol of the SAT and SPT. And they had less mortality in the more people alive, or less mortality in the people who had the intervention group. So far, we're done with the sedation. I'm just gonna have a few slides about the delirium. I'll just stop here for a few seconds, and if you have anyone have any question.
Yes. Anybody have any question? Yeah, just unmute. Go
Yes,
ahead.
yes, yeah, please. For spontaneous breathing trial, how many trials can I do per day?
Okay, the sound is not very clear, but if I understood you saying how many trials you can do per day for the spontaneous breathing trial, right?
Yes, I think so, yes.
Okay, so we allowed to do one spontaneous breathing trial per day. A repeating day, if you do it like 8 o'clock in the morning and the patient fails, doing it at 12 midday or 5 p.m. does not add, does not change anything. So you do it once a day, whatever time it is, and you leave them for 24 hours and you do it one more time. That's the guidelines, and this is what the study based on, and that's the recommendations. Good question. Any other question? Okay. So I'll just conclude by a few words about the delirium. Delirium is what we call the rock in the ICU, the monster of the ICU. We are, as clinicians, we tend to say, hey, he's very agitated, and we just walk away, or he's depressed and we walk away. And unfortunately, this is what we do to our patients. Or if we are being aggressive, we call the psych people and say, hey, can you come and look at this crazy patient? And what they will do, they give haloperidol and walk away. We have to understand delirium to deal with it. If we don't understand it, we will never figure out. We still having a lot of big questions about delirium and how we approach these patients, how we assess these patients. It's a forgotten again, monster in the ICU. So it affects, look at the figure here, almost 80% of your ICU patient will have a delirium, some sort of delirium, whether a mild, moderate, severe, with its different types, but they will have a delirium. Delirium means a fluctuated mental stats. 1 minute your patient is awake and aggressive, and the other minute he's sleeping, and he have disorganized thoughts, doesn't make sense of what he's saying. You ask him where you are, he doesn't know. What do you do? He couldn't remember. He talks nonsense, right? Delirium comes in 3 forms. Either you have a hyperactive delirium, and this is the kind of patient who creates trouble, and the nurse will call you every 15 minutes, 20 minutes, and saying he's pulling his IV, he pulled his NG tube, he extubated himself, he's using foul language, he's being aggressive, he screams. This is the hyperactive one. The second type is the hypoactive one. This is what we think he's depressed. Oh, he's quiet. Oh, he's behaving. He's delirious, guys. He's calm, withdrawn. He doesn't care about what's happening around him. He looks very depressed. And these kind of people, they die. They have a high mortality. And the third type is the mixed one. And the mixed one is the most common one. So you see sometimes he's sleeping and calm and comfortable, and you think he's behaving, and half an hour later, the nurse will call you because he's creating some problems there. What the guideline says about delirium, it says it's high incidence. You have to watch for these people, people who have a dementia, old people, for example, 70s, 80s who are demented. It's more common in hypertensive, alcoholics, definitely, right? People who presents to you with a coma, or patient who presents to you with a high Apache score, then basically they are very sick. And again, the B is the level of evidence. Definitely associated with a high mortality. Your patient will stay longer in your IC because they cannot handle him in the floor because he's been very aggressive. Definitely will be a longer time in the hospital in general, right? And once you discharge them, if you follow them, they will lose their job. They will have some marital stats. They will have a fight with their family and wives or whoever they live with, and kids. They will have a lot of social and cognitive problems. Unfortunately, all sedatives will cause this problem, and all sedated patients should have a CAM-ICU scale. And if you Google it again, it's very easy to do. benzodiazepines is a risk factor nowadays. 80% of your patient in benzodiazepines will have some degree or sort of delirium. There is conflicting data about other stuff we use like opiates and propofol. Definitely is the Presidex or the dexmedetomidine has nothing to do with delirium. Actually, we used the Presidex to treat delirium, though there's no evidence base there. But the problem with this delirium, there is no recommended medications. Everything we use, like I'm just going to highlight the haloperidol here, is there's no evidence that it helps, but it just controls the symptoms basically. So a few words about haloperidol. Stabilizes the cerebral function by antagonizing or work as antagonist for dopamine receptors in the basal ganglia. It have a very long half-life, so watch it. Be careful when you're given big doses. I've seen people given 5-10 milligram at the first dose. Dosing of haloperidol is kind of art, so you have to really start slow and watch your patient, and you double your dose till you have the effect. I believe here 15-20 minutes is a short time here, but if you give 2 milligram, wait for a half an hour at least. Your patient is still agitated, still crazy, still fighting, still pulling things and swearing at people, then you double the dose. Make it 4 and see what's the effect. We'll wait for another half an hour till you hit your target dose. Don't start high at the beginning, especially in elderly patient. Definitely inhibits the hallucination, delusions. Why? Because it makes the patient sleep. He just basically goes to sleep, calm down, slow down, but does not treat the delirium itself. It's a dose-dependent QT prolongation. We always worry about the QT interval prolongation. If you have someone with no cardiac issues, young, he can handle any dose, I believe. But if you have someone with the cardiac issues, some rhythm problems, and you're giving them a hefty doses, then you have to watch for the QT interval, and you do daily ECG in these people, or as required. It may prolong the post-traumatic amnesia. Some people use atypical neuroleptics. There's no data supports the use of neuroleptic. Where I practice, we use a lot of quetiapine or Seroquel, but again, there's no data supports the use of these medications. And I conclude by this study. If you, or this slide, if you have any question, please go ahead.
Any question or comment, please?
Either we did a good job, or everyone is sleeping, because we're talking about sedation here.
That's a good job, Dr. Ahmed. Actually, as per agreement with the medical.
Okay, thank you, everyone.
Yeah, thank you, Dr. Ahmed.
I'm sorry?
At the end, I want from you like advice, like 1 minute, 2 minute advice about, like from your experience, about how to deal with the agitated patient.
About what? About
like any advice about
well,
this?
agitated patient. It's if it just we. About what?
Like about general advice. I mean, not specific. Whatever you want to give advice for our colleague in Palestine.
For sedation. For sedation, unfortunately, they didn't have the magic drug there. So if you guys using, try to use propofol as much as you can. Try to be careful with the propofol, so don't use it for a long time. If you use benzodiazepines, start with midazolam. If you're using boluses, always start with boluses. Don't start with infusion straight away. If you not control it with boluses, of course, you have to go for infusion. If you use an infusion, use the Ativan or the lorazepam, because it will be cheaper for you, and you can save, as he said, a lot of money.
Yeah.
Make sure you have a sedation vacation every day in your patient once they are stable. Try to have a protocol in your unit. So everyone sticks to this protocol, because we as a practitioner, unfortunately, I work, for example, with 18 consultants, and every single one of them have his own way of doing sedation. So I put someone in Presidex, someone will come next day and put him on propofol. The other one will come and use midazolam. So it would be nice to have a protocol. You sit there and you say, this is what we're gonna do to our patient. Of course, there will be exceptions for some of these patients, but hey, nothing is perfect. So you agree about protocol, you stick with the protocol. Your nurses get used to the protocol. Will make life easier for you and for your nurses. And again, sedation vacation, awakening trial every day once your patient is stable. They're very useful, they're very helpful. They reduce the side effects or the complications with these medications, like we mentioned, the delirium and the hypotension and so on and so forth. And of course, reduces the length of stay, especially in this difficult period when you have a lot of sick patient, COVID patient waiting in the ER to be admitted. Every little bit helps. So think about it this way.
شكرا جزيلا دكتور أحمد.
All right. You're welcome. Thank you very much for having me, and all the best. And if you have guys any questions about anything, you can talk to Dr. Muhammad, and I'll be more than happy to come back or answer it in private or whatever works for you. Thank you.
There is one comment from Dr. Amjad. He said, Dr. Ahmed, thank you very much for informative lecture.
Yes.
Could you give us the PowerPoint to read it again? And if you cannot, tell us from where we can find good source to read the drugs.
I can give you the PowerPoint, Muhammad, and you pass to everyone there. Is that okay?
Yeah, sure. And the lecture is recorded. We will upload it in the YouTube within a few days, inshallah, after the course finished. Yeah. Any other comment or question? Just go ahead.
All right. Thank you.
Shukran.
Thanks, everyone.
Shukran. Thank you, Dr. Ahmed, very much. As per agreement with the medical college in Gaza, we will do 10 evaluation quiz at the end. For each lecture will be one simple question. Whoever attend will pass them very easily, and he will get the certificate on behalf of the Qatar Critical Care Society and IUG Medical School. So the attendance is important, and also the interactive. Thank you for everyone who interact with us today in both lecture and at the end. Thank you very much, Dr. Ahmed, again, and assalamu alaikum.
Salam wa rahmatullahi wa barakatuh.
We'll end the session now. Thank you.